Good morning, everyone. It's great to be here.
I'm not. Okay. Well, Helen first.
It's great to be here and share the Aspire project with you all. My job this morning is to introduce the Aspire project to you all and to explore what spirometry could be, how it could be used differently as a test for respiratory conditions. Now, for the people in the room who maybe haven't got a clinical background, I thought it was really important to just establish what spirometry is. It's the gold standard diagnostic that's recommended by NICE and other recognised bodies as a test for COPD and asthma and other respiratory conditions. So, thanks, Steve. Let me outline to you some of the background of the Aspire project. There were four main things that I wanted to highlight on this slide. The first was that it was done post-pandemic. The second is that we were looking at spirometry as a solution for a backlog of patients on the waiting list. The third is that it was to align with the GM and NHS goals that Dee is going to expand on later. And the last thing is that it involved collaborative working with other partners. And that was really important. It's 34. Oh, sorry. So during the pandemic, spirometry was limited due to the risk of infection with the test, resulting in a massive backlog of patients waiting post-pandemic testing. And it was estimated at the time that Aspire started that there was 70,000 patients awaiting spirometry within Greater Manchester. The backlog created several challenges, and this included inequity in accessing diagnostic tests. Incorrect diagnosis was been taken from clinical history taking through the pandemic rather than necessarily having a confirmed diagnostic. This led to an increased avoidable hospital admissions, and it also led to delayed treatments where patients weren't fully optimised with their care. This in turn increased the use of limited resources within the system, increasing costs and creating bottlenecks. And the biggest, most concerning outcome for me as a nurse was that there were very poor outcomes for patients. So we had a very big challenge for respiratory services within Greater Manchester. Yes, please. So the next question is, can we modernise the diagnostic pathway to improve access via a patient-centred model? So remote spirometry was explored as a potential solution. As I've already aligned, my colleague Dee is going to speak further about the alignment with the NHS goals within the system. And lastly, and most importantly, was the aspect that the Aspire project was working collaboratively with our pharma colleagues. Highlighted in red here on the screen shows where the remote spirometry sits within the Advanced Diagnostic Accelerator arm of the Health Innovation Accelerator programme that Laura's just introduced to us. And as she said, the purpose of the programme was to speed up the development and adoption of new technologies and diagnostics within the system. And it focuses on improving patient care across the GM population and to make a real difference. It's funded by Innovate UK, a national agency, bringing public intervention into targeted healthcare innovation. So finally, my last slide. The project delivery is going to be covered in greater detail as we develop the presentation this morning. But I'd just like to share a really high-level overview at this stage. Aspire was a pilot to test the delivery of remote spirometry as opposed to face-to-face testing. What it did was test the feasibility, operational delivery, and feedback from patients and clinicians. Patients were recruited from the spirometry waiting lists that we'd established already via one of the local hospitals within GM. Remote spirometry was performed at home, supported by a physiologist as a coach. And the aim was to ascertain whether this could be offered as an alternative to face-to-face spirometry within Greater Manchester. I'm now going to hand over to Dee, who's going to describe the clinical model in more detail. Thank you.
Thanks, Helen. The clinical model was based on 3 shifts in healthcare, and our aim was to look at system benefits and service user benefits. And obviously, it's a big move from hospital to home community Spiro in Proof of Value 1 to support the current pathways. We knew the remote spirometry would fit nicely into the primary care and community diagnosis. And our initial aim of POV1 was that it would be a diagnostic tool, but it became clear quite early on, actually, it couldn't be a fully diagnostic tool because we couldn't offer reversibility because of BTS gold standards. So it became a rule-out tool with the benefit of ruling out approximately 50% of patients. So that changed our focus very slightly, and the focus was on access, backlog reduction, and earlier diagnosis in underserved groups. And if you look at a rule-out tool that reduces it by 50%, obviously that's going to reduce your backlog straight away. You may have patients that have been misdiagnosed. So if 50% are told they've not got COPD, but they've still got other symptoms, then they will need further investigation. And a lot of them, it seems to link up to cardiovascular. And obviously, if 50% of patients are ruled out, that waiting list for those patients who really need spirometry and reversibility, hopefully they would have accessed that quicker. We did have, because this was very different, we had clear eligibility and training requirements for our patients. And the Aspire model worked really well because we had ARTP trained physiologists who actually, once a patient booked one of these remote spirometry appointments, they were coached completely by that physiologist. It was a phone with a face-to-face video being fully coached through the whole procedure. So it worked really well. The other thing was the consultants over the project, Binny and Jenny Hoyle, kept full control over the whole procedure and decision making, and primary care was supported with clear eligibility and guidance. Some of the service user for the patients, some of the benefits, we saw great flexibility in terms of appointments because patients were working. They could have an appointment at night. They could have one on a Saturday morning. They had reduced travelling. They didn't have to go in somewhere to have their testing done because it's a really mobile piece of kit. It also accessed patients that don't like to go to the GP, don't attend hospital appointments. One of the things that I will point out in POV1, because it was a proof of value of only 50 patients, we didn't incorporate translation services into the first proof of value, but they were all set up for 7 of the most common languages for POV2 when we were moving on to POV2. So just some of the outcomes that we gained from this. So we completed our clinical and operational learning, and what we realised that Proof of Value 1 provided evidence that remote spirometry actually worked clinically and operationally for patients. The biggest value was the early rule out, obviously decreasing pressure on diagnostics and improving access to patients who struggle to attend face-to-face hospital appointments. 50% of patients actually had normal lung function, which is great, because there's spin-offs from that in terms of drug budgets and other diagnostic tests. We had good clinical congruence between the hospital lab-based spirometry and what was happening at home. But I'll let Binny take you through that. That's part of the clinical model Binny's going to talk about. And we gained we gained great valuable insights into our data handling, our pathway fit, and into our kit logistics. We had a great company called Snook that AstraZeneca worked with us from AstraZeneca, and they did a focus group, and we got a group of COPD patients. We got the kit in front of them, how they could even open the box, put the SIM in the phone. So we made sure it was really user friendly, because most COPD patients, they're not your fit young patients, they're elderly, they're not always digitally savvy, and it just helped us to work through any of the glitches that we might have if a patient was doing this at home and not sat in front of a clinician telling them what to do. We had some really good documented lessons in terms of adaptability, technical planning, and early stakeholder engagement. We learned very quickly to adapt when we got technical and quality QC issues. And it really reinforced the importance of robust technical planning, device readiness, data accuracy. And in terms of our data, because what we realised with our data, working with Andy Holden, our analyst, and our early adopter GPs, we had a wealth of data on COPD, but what we couldn't work out was how many patients were diagnosed with COPD clinically who'd had spirometry. And actually, that information then helped us decide what might happen in POV2, moving on to the next phase. We also had fantastic partnerships throughout the whole programme with our industry and our clinical colleagues. And the collaboration across the system was great. We had a really focused clinical group. We had Binny Kane, we had Jenny Hoyle, we had Martina Lambert, we had physiologists. So the clinical group was great. We then had our weekly scrums with our AstraZeneca colleagues, and we worked our way through all our issues and problems. And then we had our fantastic GPs that were really insightful for this programme. So where are we at just for now? So the project paused after we completed POV1. We wrote an end of POV1 report, but we also wanted to reassess our insights and what approach would go next. So the proof of value was completed in March 25. Proof of Value 2 was not delivered due to a strategic change to scope out our CDCs and lung health checks. And you might wonder why we pivoted, but we knew there were going to be from POV1, viability issues in primary care with our technical architecture and delivery of the IT systems. We also realised from the data that to recruit 1,000 patients from the GPs, based on the data that we gleaned from POV1, we would probably have to engage with at least 70 practices to get 1,000 patients. And in terms of logistics for DPIAs, for governance and coordinating all that, a bit of a logistical nightmare, to be honest, and not necessarily guaranteed to get 1,000 patients. We also didn't have an infinite amount of time to do that. You know, we had timelines. And what we realised when we engaged with our CDC colleagues is they had huge waiting lists. And actually, if we just went to Manchester alone, they had 1,000 patients already waiting for spirometry. And we're very keen to work with us in terms of how we could get that through. We even did a short summary of how long that would take. And we could potentially get through 1,000 patients within 12 weeks planning it out, which is phenomenal when you think most patients could wait up to a year for spirometry. We also linked in with our cancer colleagues who were doing lung health checks out in the community and buses. And what we found out from them is they do have other incidental findings when they're doing their lung health checks. There are patients out there with emphysema and cardiac issues, and this spirometry would have actually fitted in really nicely in those lung health buses and targeted patients again that wouldn't normally go to GP practices, because they had a fantastic take-up rate, I think, of something like 60 to 70% of patients attending these buses. So a great way to service underserved communities. We also retained our early adopters and partners for the future iterations. We had some fantastic, we put out an expression of interest, and we got some great GPs, really proactive, who wanted to be involved in this, our early adopters. And they're the ones that gave us the insights into the waiting list, the comms materials, and what we need to do to engage our practices. And then just finally, while we were waiting and while we were writing up our proof of value, as I'm sure you can imagine, technology moves so fast. We'd already found out as POV1 was finishing, there was better technology out there that was easier for patients to use, much more cost effective, and would fit really nicely into future GM respiratory work.